Hi, my name is Peter. I'm a specialist in emergency medicine in Stockholm, originally from Denmark, and today I want to talk with you about trauma, or more specifically, not so much the decision making and non-technical skills around trauma, but more the priorities of trauma. Where is it that we need to lay our main energy when it comes to the trauma patient, especially the critically ill trauma patient. And this was a talk that I did for our Education Week 12 and 16. This is just a summary for all of our residents, but also being made available for everyone else. All right, so my main references for this talk are these: the big courses in the area, some of the guidelines in both Sweden and Denmark, and then some of the big heavy hitters in the blogosphere or the FOMED sphere. A really deep dive in massive transfusion protocols and the evidence about that. Trauma and MTP from EM cases. Cliff Reed made an amazing video on bleeding in general. And then, of course, ICU, EDU, Sarah Krager, DMCRIT, and IBCC as well have these great talks. And then a new kid on the block, the Akutvecken, which is the Swedish kind of yearly meeting, get together of all people in emergency medicine in Sweden, but their lectures are being put up on YouTube, and it's really high quality, I believe, and I think, and they're being done in English. So highly recommend to check their homepage out because there's lots of good stuff there. And then Pain and PSA. Which is also a great little known homepage made by, I think, Ruben Strayer and some others. Motov, who has the Pain-Free ED homepage. And then the St. Emlyn's TTL series, which is a new series, but comes out with small pearls and small gems of knowledge. So I highly recommend that as well. All right. A disclaimer for this: it will mainly be about bleeding and maybe some geriatric trauma. It's not everything about trauma. It's not the entire ATLS or ETC course. This is just a few topics that I felt was not well understood by the literature that I send out for our residents before, and it's an area where we often, because we're not a big trauma center, often don't practice that much. So that's why I made these specific things about trauma the priority, but you might have been able to talk, there are so many other things in trauma that you could talk about. But I think these are generalizable and quite high yield for most people in emergency medicine. All right. It's also like most of this evidence that I'll talk about is very low. There's not a lot of studies, or there might be a lot of studies, but it's small studies. And even the big studies, they don't necessarily, there might be one or two big studies within each field. And they are like that's where all knowledge comes from. So, and that's suboptimal, right? You want to have several studies in an area from several areas of the world with several teams being involved, coming to the same conclusion. Then it will be externally validated in many ways and generalizable. So that's not what we have in trauma, at least not in most areas of trauma. So that's just a disclaimer here. There are some big international guidelines in trauma that I'll send you to. Mainly the East Coast and the West Coast of the United States trauma guidelines. And then the evidence in bleeding in particular is extrapolated from from the trauma literature mainly. So there is other literature out there, but the big trials are mainly in trauma, and lots of the protocols being made are at least inspired by the trauma trials. And then I'll always because the evidence is quite low and it's quite scattered and it's not usually externally validated, it's up to the local guideline folks to kind of interpret this and how to use it at your shop. So always use your own guidelines, but this is just an overview of what I understand to be literature in this area. Okay, so you get your first patient here. This is a 37-year-old man who had a motorcycle accident. He's coming in as a level 1 trauma. I'll go into what that means. And then A is from pre-hospital. It's 3, but he is a, you might say, a P on an AVPU, maybe V on an AVPU, between V and P. He has a respiratory frequency of 40, SATs of 90, chest sounds normal, BP of 80 over 45, pulse of 145, is tender in the abdominal area. He doesn't. He can touch his arms a little bit, but he can't touch his legs, or he can't move his legs. There's focal deficit, neurological focal deficit, and his temperature is 33.6. He has a wound in his stomach, and also open wounds in his head and extremities. There's been tourniquets and compression put on the extremities. So a lot of you are probably thinking of how would we manage this patient, and we need a lot of people on board to do the cABCDE. So first stop major bleedings and so on, and then go on to resuscitate. But I'll rather go into what are the causes of shock here, and what would the first things be that you want. What are your priorities? What is the first things you want to do the first couple of minutes? Because opportunity cost here is really important. You will do an ABCDE, but what is the most important parts of that right now? And I have talked about in other lectures about the serial versus the parallel way of doing resuscitation. So please check those videos out. But in short, if you have a major trauma or a really critical ill patient, you need to do things in parallel. So you need small teams that are semi-autonomous, like an airway team, a or fluids team, maybe a examination of the patient team like B and C. So they will do everything in parallel, and then once they've gathered their data and done some smaller things, they'll go back to the team leader, and then they'll kind of then the team leader needs to orchestrate these teams of small teams. That's the parallel way of doing it. We might know it from doing cardiac arrests. That's kind of the same thing there. But otherwise, you'll go into the serial way of doing things, where you do A and then B and then C. So it's just two different mindsets in two different categories of patients. And whilst the parallel way of doing it gives you a lot more things done in a short amount of time, it has a high requirement of the leader and the team to be highly skilled in non-technical skills, especially communication, leadership, followership, awareness, all of these things, right? Okay. So I just wanted to show you, first of all, what is a level 1 or Niveau 1 and Niveau 2 trauma team. And it looks different in different places in Sweden, but this is the Swedish guideline from, I think, 2024, maybe 2025, when it was updated. And in general, then level 1 is if you have any of these, what you call the physiological criteria, but which is like mainly if you have had a trauma and you are A, B, or C, and even unstable, right? So if you have a blood pressure, if you need airway support, if you have a low or high respiratory frequency, or if you're a child, just if you're affected in your breathing as a child, then that's enough. Blood pressure of below 90 or no palpable radial pulses, and then your GCS of 13 or lower. So that's the physiological criteria. Then you have the anatomical criteria, which is penetrating violence or penetrating trauma to the thorax or extremities or anywhere else, like anywhere on the body. Neck, head, torso, extremities above the knee and elbow. So distal is not necessarily a trauma one if it doesn't live up to the physiological criteria, but proximal injuries on the extremities are penetrating ones. Okay. Open fractures in your head, neck and facial trauma with risk of airway compromise. If you have a deformed chest, if you have like a risk of or suspected pelvic fractures, if you have a suspected spinal cord injury, if you have more than 2 fractures in long proximal bones of your extremities, if you have amputation above your hand or foot, and if you have a big like blood on the floor kind of bleeding, and if you have a burn or an inhalation injury where the burn is more than 18%, they say. And so, of course, and we will remind you that all burns are traumas until proven otherwise. So these are the trauma 1 criteria, and the trauma 1 criteria will, at least at our hospital, activate a major team consisting of anesthesiologists with their nurses, a radiologist on the spot doing a POCUS or an EFAST, and sadly still, or in my opinion, still doing radiology like chest X-ray, which is, I think, useless when we have POCUS, because the sensitivity of finding a pneumothorax is so low when you have a lying chest X-ray, as opposed to the POCUS, which is quite high sensitivity. And then you have also like pelvic injuries. You don't need an X-ray of that necessarily. You will do a CT scan anyway, so you don't need that pelvic X-ray. You can just pack it, like do a pelvic bind, and then go to CT scan, and then in an orderly manner kind of remove it. And if it's inconclusive, the CT scan, then you'll have to afterwards consider it. But on the trauma bay, you just pack the pelvis. I think it's an opportunity cost to use X-ray at this point if you have a CT scan nearby and POCUS available. Okay, but that's my opinion. That's not necessarily how it works at your place. Okay. And then the trauma team also consists in our place of an orthopedic surgeon or someone who is represented from the orthopedics, and then a trauma team leader, which is usually we have to call down a surgeon, but they might not be available. So usually it's an emergency physician doing the trauma team leading, in consultation with the surgeon on call. And so that's kind of the full level 1 trauma. And then you have your level 2 trauma, and of course you have your when you don't call it a trauma, like when you don't go to the trauma bay, you just keep the patient in the general area and then treat them as a trauma, of course, but you don't have to have a big team doing all the assessments quickly. But the level 2 trauma is going to the trauma bay, but not inviting in all of these, like this big team, at least our place. And you might activated level 2 trauma by the mechanism of injury, more than 5 meters falling, or 3 meters if you're a child, a MVC accident without seatbelts of more than 50 kilometers an hour, if you've been catapulted out of your vehicle, meaning both bikes, I guess, and also cars, of course. If you've been squeezed, like you've been stuck in between, like in your vehicle, you've been stuck in your vehicle because of the trauma to the vehicle for more than 20 minutes, or if it's a motorcycle accident with more than 35 kilometers an hour, or if the child has been run over by a motor vehicle of some sort. There are some extra criteria that was added down here, and they're like, if none of the criteria for trauma has been achieved, but there are some observandums or something to think about anyway, where you might want to take care of this patient hastily, and maybe also as a trauma, level 2 trauma, if they're pregnant, if they're having drug, or if they're high in some way, like or drunk, if they're cold, if they have some serious comorbidities, for instance, like liver cirrhosis, where they have clotting problems, if they have a very low age or a very high age. So these might have to be prioritized up, sometimes as a level 2, sometimes just to have more eyes on them quicker than you would otherwise, so they're not in the emergency department for a long amount of time. And then there's also some additional criteria here. Down here where you have specific extra criteria, or making it more clear what they mean, and some of them are. I'm sorry, I'm might like you have a hard time reading these, but some of them are the so level 2 alarm can be the patient can live up to level 2 alarm criteria if they have without any protection been exposed to a high energy violence, or if there's major injuries despite vital signs being normal. So the physiological criteria are normal, but there are some major injuries. So it might be if they've been thrown off a horse in full when the horse is running, if they've been kicked by a horse, or stumbled, tread on by a horse, if they had a bike accident, or a skiing accident, or a ice skate accident with more than 35 kilometers an hour, or collided with something else, with something that is standing still. If you have a collision at high speed in a alpine ski hill, if you have in water or snow scooter, like water skis or snow scooter accident, and then they say, just because the patient is like spinal immobilized, doesn't mean that you need to do a trauma 2 alarm. All right, so these are the trauma criteria. What are the controversies? Well, the controversies for us are mainly that you might have, on a general night in the middle of Stockholm, you might have a lot of patients coming in having had injuries that are not part of the part of these criteria. So you might have void injuries, like a you have these electric scooters, and bikes now that have motors on them, which have a lot of weight behind them, and they can achieve quite high speeds. And they get some quite nasty facial trauma when they drive and are drunk, or drive more than one person on them and are drunk. So these patients are some of them. These patients sometimes need more extensive scans than we necessarily are doing. That's one group that we are sometimes missing, or sometimes under triaging. Another group is the elderly, of course, the silver trauma. So the patients who've been lying on the floor for a long time. We'll come back to those, but those patients, even though they have a ground level fall, they might be osteoporotic, or they might have a high index of high frailty index. And these patients, we're often missing injuries in, especially if they come into the medical part of the emergency department, because we have an emergency department where we mainly see medical. We have it's still dealt up into medical and surgical and orthopedic. So if you're working at the medical part, then you might miss the trauma part because of framing bias. You're framed to think this is a medical issue, and you don't think about the trauma involved in this, unless they have a big bleed somewhere or they're bleeding externally. So oftentimes we need to scan these patients more. I'll come back to that when we talk about the geriatric section of this lecture. Another group is the drug users, right, or the drug intoxicated patients, because they might have distracting injuries, as you might say, or they might have injuries that are not obvious to them, and they are being underplayed. It might also be masked by their drug, or their current drug level, so that they might seem they might be obtunded, and we think it's the drugs, but it's not. It might be the drugs and that they have a head bleed, right? So these are some of the, and we might. The problem is if we really, especially the drug users, if we really like where we sometimes think that the trauma 1 criteria are a problem, like in the middle of the night, you don't have that many resources, and you don't when you pull a trauma 1, when you pull a trauma 1 lever in the ED, a big team comes, right? And in the middle of the night, where there's low resources in all areas of the hospital, that's a lot of resources to pull for that. And we have a lot of patients coming in who are either medical, meaning that they have a medical reason for their physiological criteria, or that's the most likely reason. The elderly patient who's been lying on the floor, hasn't been drinking for 2 weeks, not 2 weeks, but 2 days maybe, and might be in an AFib and they have a trauma, but that's the minor part of this. We have to think about the trauma, and we have to scan them as a silver trauma, but we probably don't need a full trauma team to work them up. We need a medical team to work them up, and someone with some expertise in trauma to also not miss a trauma, but they don't need the full trauma 1. Because and sometimes you have a lot of patients coming in like this, so you have to prioritize your resources, especially during nights and during weekends, right? So that might be an over triage of these patients if we just go by the criteria. That would be my argument, at least. And it might be the same at your hospital. The main thing is that we don't miss the traumas, right? And we try to do trauma scans when it's necessary. Then another group is as we talked about, the drug users. A lot of those will have a GCS of below, of 13 or below. And that's kind of, if we have to, on a Friday or a Saturday, pull the trauma 1 on all of these patients, it will be inachievable. So we have to be selective. It will be inachievable because, for instance, my hospital is right next to the biggest emergency ward for drug users in the entire Stockholm area. So we get these patients from all over the Stockholm, the general Stockholm area, and then when they have a trauma at their place, they come to us, and so we have a lot of these patients. And it wouldn't be achievable to pull a trauma one on all of these Friday night or Saturday night. So we have to be selective, and I usually pull it when I'm really concerned or when I cannot get them to the scan, because they need to be sedated to actually like cooperate if I'm concerned about them. Most of them are walking and talking, and they happily go to the scan, or they might go home because they want to be in the scan. But then, so different approaches to these patients, and it depends on where you work. I'll also say that there are two kinds of scans, right? There's several ways of doing scans. You can either do a full trauma scan with multi-phase arterial and venous contrast. I'm not a radiologist, but that's kind of what it is, right? Arterial and venous contrast. And this is mainly to see organ bleeds and see if there's a extravasation in your pelvis. But for most just fractures, you don't need the contrast. You only need a normal non-contrast CT scan of it, and that's what we usually use in the elderly if we don't think that they're bleeding, but they just have like it's mainly for fractures that we want to see, and maybe some kind of bleeds in like head bleeds where you don't need contrast to see them. Like we don't believe that they have a abdominal organ problem or tear. So we distinguish between trauma scans with contrast and trauma scans without contrast, which are mainly used for the elderly silver trauma. Then of course you can be selective as well, also in your elderly patients. But the more frail they are and the more areas of the body they have injured, the more prone you should be to just order a full trauma scan. Yes. So going back to that was going back to our patient with the multi-trauma injuries here. We want to get ahead. Like the patient is an obvious shock. So during our cABCDE, we will put a tourniquet and compression on the areas where we really need to, and one of the main priorities will come from this mental map, right? Why is the patient in shock? So I've shown you this before, and there's generally 4 to 5 kinds of shock. I know Sarah Krager has developed this mental model even further. You can check out her videos for the reframing of the free shock model, or whatever she's calling it. It's really amazing, but it's also mainly ICU level stuff, I think. Not too relevant for the ED necessarily. But in general, I think the pump, tank, and pipes model or this model are sufficient in many ways in the ED. So you have your patient who is, you can either be hypovolemic, you can be cardiogenic shock, you can be obstructive shock, and vasodilatory shock, and then you can be dissociative shock, which I didn't put here, but that's the 5th one. In the context of trauma, the likelihood of these different shocks are different than in your your unselected patients. So these are the main ones, like your hypovolemic shock, especially obstructive and vasodilatory, maybe. So bleeding is the main reason why the patient is in shock if they've had a trauma. So one of your priorities for your patient will be to get access and then assess, are they bleeding? And if they're bleeding, can we stop the bleeding right away, as we did with the tourniquets and all? And can we, the second part of that is, can we resuscitate them right now so that we can catch them up to stability, or resuscitate them to stability, or do we need to move quickly because we will never achieve stability and go and stop the bleeding in surgery. So there's like two parts. It's like stop the bleeding and resuscitate the patient. That's the main two parts, and that's like 90%, I guess, of all trauma, like unstable trauma patients. That's what do you want to do quickly. Then, of course, we should think about the other things. So more rarely, it can be the obstructive kinds of shock, tension in thorax, tamponade. There's even case studies of hemothorax, which can tamponade, but our trauma surgeons in Karolinska would say that it's rare for a hemothorax to tamponade. So we should not be like, we should mainly put in a drain to relieve the B problem. We shouldn't be afraid of giving the patient a or giving the patient releasing something that was actually coagulated blood. We should put in the drains. That's kind of the main thing here. Okay, so. And also, well, you do have other kinds of shock, and it becomes more and more rare, right? The neurogenic shock, and of course, you can have a trauma for a medical reason. So always have that in the back of your mind if things don't add up, or if it's a single trauma injury, like a car hit a tree. Is there drugs on board? Is there a medical cause? Like, did they have an epileptic seizure? Did they have a cardiac arrhythmia? Did you have an ACS, acute coronary syndrome, something like that, right? So you should always think about the medical reason, especially in those circumstances where it's a single injury, a single solo accident. But the main takeaway here is like bleeding is 90% of all shock causes. Then there are some rarer ones, and you will check for those during your POCUS or rush exam during your traumas, or EFAS exams, whichever protocol you're doing. And if they have neurological deficits, you will think about the neurogenic ones as well, and that's important because they need different management. Bleeding needs, as we said, blood and resuscitation and stop the bleeding. These need relief of the tension. And these needs vasopressors, and these needs a map. These need a map above 80 as well. So once this patient comes in, priorities on putting in IVs and doing assessment of whether it's only this, which is the default, or it might be some of the other things. And we see this kind of thinking also during a traumatic cardiac arrest. There's 4 things that you need to do. You have to put in, like, don't do compressions or don't pump the empty heart, or as the ERC would say, down prioritize it, so that other things that are more important and more likely to save a life comes first. So that would be the 4 things: putting in an airway tube, like intubation, empirically doing 2 finger thoracostomies for potential tension pneumothorax or hemothorax, getting in IVs for the bleed, and then checking the ultrasound of the heart for checking ultrasound of the heart to see if there's tamponade. If there's tamponade, then there was the Gaza, the recent study in Gaza, showing that you could probably do a pericardiocentesis in extreme circumstances if you cannot do a thoracotomy. But the traditional teaching is that your thoracotomy, your clamshell thoracotomy, is the treatment of choice if you had a patient arresting within a few minutes of you seeing them, and you have competency in doing a clamshell. And that's it's difficult to say who actually has that, but it's mainly for penetrating trauma as well. If you have a cardiac arrest and it's only like the only reversible cause is bleeding, then there's a lot of studies from the United States telling us that the prognosis is quite bad at that point. Okay, so this is the mental map I have when I see a severely sick trauma patient. So let's go into the bleeding now then. So as I said, it's kind of twofold what we do, maybe threefold what we do in bleeding. So the main thing is stop the bleeding. If we can stop the bleeding, then everything is good. Then it's just but if we cannot stop the bleeding, then this area becomes more important. Can we resuscitate, or can we catch up to the bleeding that has already happened for the patient? And then after a while, we have to resuscitate against some goals. So that's why we are talking about these that area as well. So, but this is the main area. That's why the OABCD or the cABCD is so important, that we prioritize things first things first, to like stop the bleeding as the highest priority. Okay, so how do we stop the bleeding? Well, ATLS teaches us that there's blood on the floor and 4 to 5 or 6 more, which are areas where you can bleed out from, or you can have enough volume of blood in those areas so that you can become hemorrhagic, like you can bleed out. You couldn't bleed out from a distal fracture of your extremities, but you might be able to from a proximal one if there are several injuries involved in both legs, maybe, or then in both arms. So what are these areas? So there's blood on the floor, which means that you have an extravasation, bleeding somewhere, and it's so important to know how to do a tourniquet, or like just pre-hospitally, you could put on a tourniquet, and they can sit, I think it's 6 hours. I also always have to check that up. And if they sit there longer than 6 hours, you have to consider that limb is not viable anymore, and there might be a problem by releasing the tourniquet as well, because releasing the tourniquet will introduce potassium and other toxic, potentially toxic elements like CK or myoglobin to the rest of the system from that non-viable extremity. So there's lots of there are some experience, especially from the Ukraine war now, showing that like it's probably like beyond a certain amount of hours it's not a wise choice to release the tourniquet, sadly. So at some point it's non-viable, so you always have to note the time and then put them high and tight, right? If you don't know the side of the bleeding, put them high and tight, but if you know the side of the bleeding, then put them where just proximal to the bleeding. Don't put them over a joint. If you're intra-hospitally, then usually don't bother with the tourniquets. You can just use a blood pressure cuff. But yeah, because the blood pressure cuffs, you can just ease the pressure after a while, and then you can like see the side of the bleed, maybe put in a suture, depending on what kind of bleed it is. If you cannot access like the blood on the floor, if you cannot access the bleed, if it's on the neck maybe, or if it's somewhere where it's non-compressible, then well, in the abdomen you can do a compression. You can do compression, but if it's on the neck, you might raise the patient's one arm so that you can use the arm as a contrapost so if the patient is bleeding on the right side of the neck, you want to put pressure on the right side of the neck, but you don't want to use the left side of the neck as a contrapost, because then you will strangle the patient. So you might lift the left arm so that you could use the left arm as a contrapost for the compression. Yeah. If it's then you have your thorax. You will see this during your EFAST, and then you will do a drain, and then call a trauma surgeon, depending on like different places have different measures for this, but maybe 250 to 500 milliliters over an hour. If it keeps bleeding and that's the amount of volume that has been lost, then yes, then you will probably just talk with them. We don't have trauma surgeons at our place, so we have a lower threshold than other places might have. So look at your local guidelines for this. Abdomen, if you have free fluid in your abdomen, then yes, then you have to consider whether you should go to CT scan or OR, depending on how unstable the patient is and whether you can resuscitate them in time. The pelvis, you'll put on a pelvic binder. It's important with a pelvic binder that it's over the trochanter. It should be called a trochanter binder, and it's important with the P's so that you don't have the penis involved, and you position the feet in a internal rotation and tape the feet as well. If you don't have a pelvic binder, you could use a linen. There's different videos on EM wrap or different size on the foam sphere where you can see how to do it. Be aware that elderly ladies or males with that are osteoporotic can have ground level falls and kind of insidiously get bleeds in their vessels in the pelvis. So you might, if they have a lot of pain in the pelvis and are unstable, you should not. You should really consider doing the polytrauma CT scan on this silver patient, even though you might think it's just a fracture. If they've syncopized or if they had other indicators of shock, then you have to do a CT scan with arterial contrast to see if there's extravasation in the pelvis, because they might need some kind of intervention that is not like you need some interventional radiology kind of clotting in the vessels. Then if it's a femur or a humerus, then you'll do a PSA and reduce it. Maybe use what you call in Swedish HARE or HARA. So that's the blood on the floor and 4 more bleeding sites. There are a couple more, right? So there was it's important to mention these two, I think, because the patient can be unstable from a retroperitoneal bleed, and you will not see those on your EFAST. So if the patient is unstable and you haven't found a bleed here, no free fluid in the abdomen, nothing in the thorax, no humerus, you might consider, well, is it another kind of shock or is it retroperitoneal? So always consider in the shocky patient to do the CT scan with contrast to be able to see these things, because it might be a retroperitoneal bleed. And then in infants, because there are large heads and non-closed fontanelles, you can die from a head bleed. You can bleed out from a head bleed if you're an infant. Okay, how do we resuscitate these patients then? And we'll go back to some of the more specific cases of stopping the bleed in a few slides. More of the specifics around maybe GI bleeds and so on. All right, so how to resuscitate? Well, the main thing here is get venous access either by IO or venous access. The thing is, the important thing about the 1-2 IO kind of mindset, like you try twice with a normal way, and then afterwards you'll go to an IO. The IO is a temporary thing. You need to resuscitate through the IO, but then as fast as you can or in parallel, you will still try to get the venous access, because it is a much faster way of getting fluid into the patient. But it's better than nothing, and it's better to get this going, and you might put in multiple IOs, especially in the so the humerus is a better site than the tibia, but just be aware of that when you have your humerus. Cliff Reed did some cadaver studies showing that you should always have your thumb like the patient's thumb downwards, and you should not abduct and pull the thumb upwards, because then it will kink the needle. So you can check his videos out for that. And Ian Case has done some amazing videos as well on IO placement. Okay, then there's the thing about protocols. What are we going to give? Are we going to activate the MTP, the massive transfusion protocol, with 4 RBCs, 4 FFPs, and then 1 RBC, one thrombocytes? Or are we going to just give 2 RBCs and then see if there's a response? Depends, right? Depends on, have we stopped the bleeding? Do we know the site of the bleeding? And are we close to a center where we can stop the bleeding if we cannot stop the bleeding right now? So lots of things goes into this, and I'll encourage you to check out the EM Cases MTP discussion in the references, because it's really fascinating to hear in rural centers how they think about these things, as opposed to in urban centers. But in general, most of the time, at least at our center, it's enough to just give 2 RBCs, see where it goes, and if it goes badly, and you need more than 4 units, something like that, after 1 hour, then yes, you might want to activate the MTP. But be aware that the MTP is not very evidence-based. So, yeah, you can check out Justin Morgenstern's blogs for that. Sorry. Then we also want to avoid giving too many clear fluids. There was, I think it was called the refill trial pre-hospitally, which showed against what the convention is, that so we're told that don't pop the cloth, right? The more clear fluids we're giving them, the more we might injure the glycocalyx. We might also dilute the coagulation factors of the patient, and we might add to this like kind of shock kind of like state, or this kind of inflammation state that big trauma patients have. So we might overhydrate them with clear fluids that are not necessary. So there are several arguments for not giving them, but in the studies, for what I know, there might be a slight signal of harm, but there are significant outliers in the studies. So, for instance, the refill trial, which was like a pre-hospital trial, trying to distinguish between should we give fluids or blood, right? Clear fluids or blood in the pre-hospital area, and I don't think there's any difference. So that doesn't necessarily extrapolate to giving it in the hospital and so on. So we probably should avoid giving too much, but if you don't have anything else to give right now, then 500 milliliters or lifting legs, right? Lifting the patient's legs to outer perfuse is also a good way of seeing whether they are a responder or not. But especially the elderly are usually baseline a little bit dehydrated, so there might be an argument to give it to the elderly, especially just 500 milliliters. Then your tranexamic acid. All the evidence here comes from the CRASH 2 study and should be given as early as possible. In the CRASH 2 study, it was before 3 hours and not afterwards, because there might be a signal of harm then. But gladly, even earlier, so like as fast as possible is now the consensus. And different protocols will say 1 or 2 grams. If you give 1 gram, you have to give another gram intrahospitally, but otherwise you can just give 2 up front. Yeah. And then reverse whatever blood thinners there are on board, if it or consider during it, I would say, depending on how big the bleed is, right? And how good the blood thinner reversing agent is, and when the intake of the blood thinner was, and so on. So it's a complex and often expensive decision to do. And then your prior to is giving these additional things like calcium. So the Swedish guideline was updated now to give empirically if you have a big bleed, but many of the international guidelines would say don't give it empirically and don't give it too much. It's something that is more and more important the more RBCs you give, because the citrate, the citric acid or the citrate, I think in the RBCs will make the calcium go down with time. So the more transfusions you give, many places they will just empirically have a board where they say, oh, we gave 4 RBCs, then we'll give 1 calcium. To my knowledge, there's only a few, there was only 1 or 2 studies on this, and they were negative for giving them empirically. So, but they're connected to how many transfusions you're giving, so just keep an eye on it. Fibrinogen, or similar, which, like earlier, you could give FFP, and you can get concentrated fibrinogen by giving them what you call cryo. In Scandinavia, we have fibrinogen, and you could give it empirically, which would be 4 grams. But to my knowledge, there's also only 1 study that said you shouldn't give it empirically. So unless it's like a really, really like critically ill patient where you want to give the kitchen sink, I wouldn't give it empirically. But the Swedish guidelines would now say in big bleeds, give calcium and fibrinogen empirically by activating the MCP. But other studies would say check the blood samples, like the calcium and the fibrinogen levels first. Then how do we control, like how do we know when we are resuscitated, like stably resuscitating the patient? What are the goals? So optimally, probably, would be to have a TEC, thromboelastographic, or a ROTEM, controlled resuscitation where the TEC or ROTEM is right next to the patient bedside at the trauma bay. I've never worked at a place that have it bedside, but I have worked in several places that have it in the ICU. And the thing is, the argument is, the problem, the other method, the conventional method, is just doing blood samples. But there might be a delay of maybe an hour or 2, depending on where you are for the blood samples, right? So you might, when you're resuscitating kind of in the past. So we're resuscitating again, like this is where the patient was. If you're doing blood samples, this is where the patient was 2 hours ago. Where are they now? So the argument for TEC ROTEM is that you'll give a much more specific and much more timely resuscitation of the patient. I don't know of the studies in this area, but I'm told that it seems like this is the future. I've been told this all during my medical career, and we might be a bit biased in Denmark because I think we have been part of the development of this. But yeah, if you don't have TEC, or if it's not in reach of you, then these are some of the goals, like different goals depending on the local protocols. These are from the Swedish guideline from 2026. And we're trying to get a HB over 70 to 90. Yeah, sorry, I that's that's the Swedish references. I can't remember the other ones. TBK thrombocytes above 50. That's also controversial. But yeah, that's mainly big if there's ongoing bleed. If it's not ongoing, then you probably can go further down. And over 100 if there's a traumatic brain injury. Fibrinogen over 2.5, and there's a point of giving enough fibrinogen. Give 4 grams instead of 2, with the EM cases take-home point. PK or INR below 1.5. I don't know why we're testing too much for that. And APT should be normalizing. pH, yeah, this is the lethal triangle kind of. You want to have the patient normal calcemic, normal temperature, and a pH that's normal. And I guess does bicarb have a place here? I don't think so. I don't think there's good evidence for it, but maybe. Probably you just have to treat the patient's underlying condition. And lactate is a good indicator of badness in trauma with these bleeding patients. You want to have the hypertension or the blood pressure of more than 60 to 65 in MAP, unless the patient is a kid, because then tachycardia is what you want to go for. They will only drop their blood pressure really late, so think about that. And neurotrauma, you want from weak evidence, I would say. And there was recently a spinal injury RCT that said that there was no difference, but the power calculation there was so bad. So there's very little evidence what I know about these MAP targets. It's mainly a mechanistic argument. But until further studies are done, we should probably aim for a MAP of over 75, 80, or a systolic blood pressure of over 110, something like that. Ask your neurosurgeon in those cases as well what they want. Okay, so that's like bleeding. When talking about coagulopathy, just a small thing like clear fluids we talked about, that will probably be the worst thing to give. Then 441 is probably the second worst thing to give. Whole blood stored is better, and then whole blood fresh is probably the best from a standpoint of mechanism. But the studies haven't really shown this, and fresh whole blood is not something you have outside of the army, so it's stored whole blood that might be something that we consider giving at some point, but the studies have not shown the benefit yet and might not ever do it. This is a tech, there's the tech is like a small amount of blood being, and then you have it in a small tube, and you have a stick being revolved into in the fluid, in the blood, and then by measuring how easy or how sticky it is, you get this like clot formation graph. And depending on the graph, then you can have different specific treatments for specific graphs. And we usually have these pocket cards when we have these, like when you worked in Denmark, we had pocket cards to interpret these. We might even have a consultant whether we could ask. But otherwise, you have these tech for dummies. If you have this is a normal curve. This is where you need to give cryo or fibrinogen. This is where you have to give FFP, platelets, TXA, and so on. So yeah, there's different. This gives a more specific resuscitation than we could with the blood samples. Yeah. Okay. Then for reversing agents, this is from narkoseguiden.se. It's a good summarizing slide as well for what we just talked about, but I want you to keep your attention on these things over here. So talking about reversing agents. So many reversing agents are not specific. They are not an antidote, but they are more like they help the coagulation cascade, help balance it up. But some of them are specific, right? So for warfarin, it all depends on what kind of RNR they have, and you can always just give them PCC. Like if you can give them quinaquione or K vitamin, and depending on how big the bleed is, you might want to give it on how long you want to reverse them. You might give it a little bit or a lot, and PCC is a much faster one. So you give the quinaquione for the longer reversing, and the PCC for the quick one, and you often give them both so that you both have the quick and they will also be reversed tomorrow. So, but it's about weight and it's about the INR. But if you don't know, then usually you just give something and then you add up after that. So you might give 1,500 or 2,000, and then you can always add up afterwards. This will give quite a lot, because it's also the same that we give empirically for Xarelto or Eliquis or Elixiana, because these drugs don't have any specific antidote, but this helps, as I understand it, stabilize. There is one specific antidote that's come out called andexanet alpha, but the evidence behind that is really weak and has not been improved in Scandinavia for that reason. However, in many international guidelines, for instance, the ICH guideline of the American Heart Association, so the spontaneous head bleed, stroke bleed, they would recommend giving it in certain circumstances, and that's outside of what we would do in Scandinavia. So they're highly sponsored drug, and the studies don't really show that much benefit and mainly harm. So that's what you can check out First 10EM's take on the andexanet alpha trials. Then you have other things that I've never given actually, protamine in heparins, and also protamine sulfate. I've never given a Novo 7 either. But Praxbind I've given several times, and there's always, you have to give it over more than one time usually, and it's really expensive. So it's only in specific circumstances you have to give it. So I've never given. I don't think I've ever given these thrombocyte transfusions or desmopressin for these either. So it really, like, most patients, I've never needed to give much more than Octaplex for reversing agents, or maybe Quinacione, maybe Praxbind, but yeah. And I promised to talk a little bit about these specific areas of how to stop the bleed. So we talked about, like, blood on the floor and 4 more, compression, tourniquets, but if you have a scalp wound, then I'll recommend just putting compression on it and then doing a figure 8 suture over where you think the bleed is, and just a big needle, rough sutures to begin with. These are usually elderly patients who are demented or frail, or both, on DOAC. So you need to kind of do some sutures and quickly, because they can bleed quite massively from these. If you just make them stay put in the ED. So yeah, that's what I would do. And then once you've closed the wound, like big rough sutures, figure 8 sutures, you can check out EM Wrap for how to do those. And once you've done it, then you might continue with some smaller sutures. And usually these wounds, they bleed anyway. They bleed still after, and it's important then to put on a big compression turban or something like that on these scalp wounds. And sometimes these patients has to be admitted because they will take off their compression because of their confusion or dementia. But that's the main thing for those. Epistaxis, anterior and posterior. I'm no expert at these. I usually put in I usually make them sit and compress for a while, and it's really important that they actually do it. Usually they don't do it, so they have to compress their nose, and if they don't, then I'll encourage them to do it again. That's so most of these, they actually stop by doing that. And they should be leaning forward, not backwards, because then they won't swallow the blood and throw it up afterwards. But if this doesn't help, then you'll have to pack them. And I usually don't pack them, but many of my colleagues do. And we didn't have the tradition of doing it when I worked in Denmark, so I haven't really caught on with the packing of these patients. We don't see too many of them either, so I'll usually just put in a rapid rhino. And you can put in a rapid rhino either with a posterior balloon or an anterior balloon, and depends on where you think the bleed is. You don't have to blow up the posterior balloon, but nose and throat doctors can give you more specific guides on this. But in general, rapid rhino, and if that doesn't work, then you'll have to put in a Foley. And the Foley, you'll put into the patient's nose, and then see through the mouth whether it's come all the way through, and then blow it up, and then you have to put something in between the nostril and the patient's the nostril and the Foley, so they don't get any compression wounds. And then usually you have to send them to an ENT doctor anyway, like that, because they have to be they have to be burned on the they have to be cauterized on the place of the bleeding. All right. Post tonsillectomy bleeds. EM cases did a great quick hits on this, so check that out if you want to. But in general, you have to put lateral, like you have to put tranexamic, like you have a small cloth with tranexamic acid and put on pressure. The problem is if they're bleeding a lot, then they're bleeding it down into their airway. So you have to think about airway management, and if they're shocky already, then you can't really intubate them unless they're cooperative to awake intubation. So these patients can become really bad really quickly. So have respect for post tonsillectomy bleeds or tonsillar bleeds. You can give nebulized tranexamic acid, but I've only done it once, I think, and it's not. I mean, you should think about ENT management quickly, and get the IV and do all the resuscitation things as well. Think about airway in these patients. Then penetrating trauma. It's important to, if you have penetrating trauma anywhere in the body, then always put on some kind of, when you're doing radiology, put on small capsules so that the radiologist can see where the entry wound is. If it's on the thorax, put on a 3-part band so that they don't get a sucking wound or a kissing wound. And then you might explore with a Foley. I have no experience doing that. But if there's still a foreign body in the wound, then don't pull that out until you know that you can expose the area operatively. So, for instance, there was a case that was in the news in Sweden a couple of years ago with a military what you call someone doing the military or trying to go into the military. Who fell on his bayonet, and it was lodged in his skull. And they considered, I was doing my trauma rotation at that point, and they considered pulling it out during the operation, during the in the emergency room, but they opted to not do so, and that was wise because once they pulled it out in the operating theater, it apparently bled quite a lot. So it's important to not. It's important to not. It's important to not do. To not pull out any foreign body in the body. Until it's operatively exposed, because it can bleed, and if you cannot compress that bleeding afterwards, then you have a problem. Then you have an internal bleed that you cannot stop, either in the lung or in the brain or anywhere. The pelvis, we talked about pelvic binder and splints and so on. And arterial limb bleeds, we talked about direct pressure, elevation, as we and then tourniquets, and then you can always like ease the pressure, see if you can put in a suture. Yeah. Mid-phase fractures, these are tricky. You have also an airway management problem, so you want to do intubation or you want to manage airways, I guess, and then you have to just pack the airway afterwards so that it doesn't bleed. All right. Hemoptysis, well, CXA, and then EM Cases did a great podcast on hemoptysis as well, so check that out with Scott Weingart. But I think they should lie on the lung that is bleeding. So the lung that is bleeding should be down so that it's compressed, and then inhale tranexamic acid. And then you can intubate them as well in the healthy lung, so that you can compress the other one. Different techniques here, but yeah, I've very little experience with these patients. only had one, and it wasn't too severe. Hematemesis. So it really depends whether this patient is a upper GI bleed from a cirrhosis, like it might be a visceral bleed, or it's an upper GI bleed from ulcer. The problem is you don't always know, right? So many of the patients with cirrhosis also have ulcers. So I guess EM Cases did a great podcast on this as well, on upper GI bleeds, and one of the surprising things about this area is that PPI doesn't really work in the acute phase anyway. It works mainly like it has no place in the emergency room, and it's only an opportunity cost to give it. So that's down the line. We give it, but not emergently. What is important to give is antibiotics, because if it's a cirrhotic patient, then antibiotics and terlipressin or desmopressin, those are the ones that are important to give, especially antibiotics, because that has a mortality reduction. It's quite significant. And otherwise, you have to stop the bleeding and somehow. And it's the age-old paradox: the patient is too sick for the scope, or they're doing too well for the scope. So this is the gastroscopy paradox. But in general, unless they're critically ill, they can wait until tomorrow. You have to be stabilized. They have to stabilize and be monitored, but then you can wait until tomorrow to be scoped. If it's a visceral bleed, then usually they have to go up right away. And in some places you have Sengstegen and Blakemore tubes, but we just give them. We just at our place we just go right up to the OR and scope them right away. Intracranial bleeds, yes. So if it's spontaneous subarachnoid, then yes, you have to reverse them. And as we talked about, there is different BP targets, and they're controversial as well. And if it's a traumatic bleed, you want to map over 80. But if it's non-traumatic, you want the blood pressure to go down within the first hour, around to maybe 160. Unless it's a very, very high blood pressure to begin with, then you want to decrease more slowly. Check out the guidelines on your local on your local protocols for these things. And then you might need sometimes neurosurgical intervention, especially in subarachnoids, but not so much in ICHs, sometimes, depending on the size. There's more of a niche decision there, but in SAH, then always, yeah. You might, especially if the bleed is in your posterior aspect of your brain, in the cerebellum, then there's a high risk of herniation, so you might need to remove the skull neurosurgically. You might also put in a drain. There's different ways of doing these things, right? So, but always consult your neurosurgeon with these ICHs, especially the SAHs. These should go to the neurosurgical right away. As we talked about, and then bleeding in obstetrics, you have the 4 T's: the tone, tissue, trauma, and thrombin. Check out first 10 EM's walkthrough of the 4 T's. There's lots of other things that you do. You will massage the uterus. I've done that several times because of my experience in obstetrics. So right as the baby is born, you massage the uterus in and down so that you get that uterus small as a small ball. You might give them syncytonin or oxytocin, synthetic oxytocin, and you will do the 4 T's. And if the tone is good, you just compressed, right? The tissue, there's no trauma. You might check for trauma, whether there's bleeding, and then they don't have a coagulopathy. Then what is left is the tissue. So once the placenta comes out, you will check the placenta, and if it's not all there, then you will have to go in and scoop it out in the operation theater. Yeah. The other bleeds I'm no expert in. But usually, first, one of the things that I want to say about vaginal bleeds is that it's important when you have especially elderly patients coming in, that you check their all 3 holes before considering that it's a vaginal bleed, because it might be a GI bleed. That's much more serious if that's fresh blood. So check the anus, see if there's melena or fresh blood, and check put in a catheter to see if there's hematuria, and then do a vaginal exam. All right, so it's quite easy, but sometimes if there's blood in the diaper of an elderly lady, then you don't quite know where the bleed is coming from, and there's vastly different workups and like what to do with these is very different depending on where the bleeds come from. Then yeah, and pediatric bleeds, yeah, and this is all from Cliff Reed's video. You can check that out. It's really highly recommended. Okay, so just wanted to show you. This is from 2019. This is the guideline in Sweden. The SSTH, the Svensk Sällskap för Trombos och Hemostas. But they recently came out with this in March. This is a new one. All right. When do we do MTP and when do we do 2 bags of RBC and weight? So Sarah Krager did a great podcast on this, and also the EM Cases MTP podcast is really good on this. So in general, MTP, the main reason for giving MTP is to give a balanced as possible resuscitation without risking more coagulopathy of the patient. There are no specific criteria. There's lots of criteria or scores to try to help us. The TASH score, the ABC score, the RABIT score, the shock index, but none of them are really good. And like I think the EM cases think that the RABIT score is probably the best, sensitivity of 80 and specificity of 90. So, and you activate if they have more than 1 point. So penetrating injury, positive EFAST, pelvic fracture, or shock index of more than 1. So, well, sure. But in general, you have to look at the trends as much as you're looking at the absolutes. So are they trending downwards? Then despite giving 2 RBCs, and yes, you should probably activate, but there are certain things that like what should inch you towards doing the MTP activation? Well, what kind of bleeding is it? Well, if it's a GI bleed, then probably not. Most of the there is some weak evidence that GI bleeds probably don't need MTP activation, and especially the cirrhotic patients can be at risk of being over resuscitated. Of course, if they're really crashing and there's an ulcer bleed, then yes, you will give it, but be considerate of not giving it there, or it might not be needed. Check out EM Cases for the discussion on that in their MTP talk. GYN bleed a lot, and they might need activation, and trauma also. So that's just weak. That's my own, what I've heard from the different podcasts. Now, if there's ongoing bleeds and you're giving more than 4 RBC bags an hour, then you can also activate. And then if there's massive bleed with shock, especially if you cannot stop the bleed right now, then you will also activate. So, and Sarah Krager and Petrosonak's rules ABC after 3. So give 2 to 3 RBCs, and then ask 3 questions. How sick is my patient? Do they have coagulopathy, and will they need more than the 4 units? And is there a site of active bleeding? Do they need definitive hemostasis? So it's kind of what we talked about here. So there's no really good answer here, but it's somewhere in these lines that we will consider activating these the MTP. And once you activate the MTP, you will need to have will need to stop it as well at some point. So it's an active activation, and it's an active stop. And Petrosoniak, I think, encouraged us to don't stop too early. Once it's once you stop, it's hard to get it going again. So don't stop too early. And this is just from the MTP management in Sweden. 4 units of RBC, 4 units of fresh frozen plasma, 1 unit of thrombocytes. And you don't have to give this all, like, this is over maybe 6 or 8 hours that it has to be balanced. You don't have to balance it right at every, like, at every time, because the fresh frozen plasma takes a long time to thaw. So you'll be giving the RBCs right up first, and then you'll give the rest as it comes. But you have to have some kind of blackboard where you know how much are you giving and how much have been giving. All right, and then you'll give fibrinogen 4 grams, more than 2 grams, and then you'll give tranexamic acid right up front, calcium as needed. Yeah. And we showed this before. All right. So we talked about these mental maps. We talked about the bleeding now in shock. The other ones we'll not talk too much about, but we'll just talk about the neurogenic one. So neurogenic shock and increased ICP. So this is what you call the Monroe-Kelly doctrine. Cerebral perfusion pressure is the same as MAP minus ICP. So you have blood pressure going up to the brain minus the pressure in the brain. Makes sense. What you want to do is MAP over 80, right, as we talked about, or a little bit different depending on which guidelines you look at for children. You will give them, to go up there, you will give vasopressors and sodium high in, like, fluids that are high in sodium, because you don't want to decrease the sodium at any point. You want to have a saturation around 94 to 98 according to the Danish guidelines. You want to have a elevated head around 15 to 30 degrees to increase venous return or venous drainage from the head. You want to have a sodium of above at least 137 to 144. Depends, different guidelines says different things here, but at least don't give them any clear fluids, or don't give them any glucose or hypotonic fluids. They need glucose. They need sodium containing fluids. Remove the cervical collar if they have one. Give pain management, and so that they don't have to use the Valsalva. Obstipation management, catheter management, and then you consider neuroprotective intubation. And but these are the things that we'll do in the ED. These things. Then we could discuss whether we should do a neuroprotective intubation if they're really, like, if they're going down in GCS, and then because then we want to keep the PCO2 on a steady, like, not too much, not too little, and doing that is a balancing act where you need to do VBGs, and you have your entitled CO2, and you have to calibrate with your VBGs or ABGs, and to see where you're going with your ventilation effort. And then you'll give mannitol or high. There's a discussion. They're probably quite similar, but there's a discussion which ones to give. Check out the expert podcasts on this, especially the EM cases, and Petrosoniak's talk about these things. But a lot of these basic things are missed, I think, in many of these high ICP patients. So remember these things. It's important that we do these things good and well. And then we can always think about, well, should this patient be intubated from a neuroprotective standpoint? In trauma, one of the main discussion points are usually, well, the patient is both bleeding out and also have a head bleed. Which one should we prioritize? It's because C comes before D, but if you have a big D problem, is it a life worth saving, and so on, if it continues? So that's always a heated discussion, it seems like, in many of these trauma centers. Here's a guideline, the only Scandinavian guideline I know on ICP management. It's from DASIM, the Danish Association for Anesthesiology. And here's their neuroprotective pocket guide. Okay, pain in trauma. So I don't know any guidelines on this, but I do know that Petrosoniak and Hicks have done this on the homepage Pain and PSA, and they've also been on EM cases with this. So in general, it's very much like it's a matter of priorities, right? So you want to give the patient pain management, but also you don't want to drop their blood pressure. So you can give them, if they're in the green, then it's all right. If they're in the yellow, shock or occult shock, pleural perfused extremities and so on, then you might want to give a lower dose. And if you're here in profound shock, then usually they're not awake. And usually you will, if you want to at some point intubate them as well, then you'll usually do ketamine, and that's usually all right. But please check out for more details on this. Check out the pain and PSA, because we should pain manage all of these patients, but we should start low, go slow if they are in occult shock. If they're doing fine, then pain manage them all you can. There's both non-pharmacological ways as well, by reducing fractures and so on and so forth. But there's also the medical things that we have to think about here. And then pain management is also about getting the room more calm. So it might be worthwhile on a humanitarian basis to just intubate the patient early on if it's safe for the patient. Okay, TXA for everything, anything. So TXA was widely popular a couple of years ago, and since then, maybe the last 5 or 10 years, more and more skeptical studies have come out to kind of burst the TXA bubble. EM cases did the best walkthrough of this, along with Justin Morgenstern and Ken Milne that I've known. So please check that out if you are interested. But in general, their summary is the pattern of research findings for TXA for most indications is that small, lower quality studies are positive, which is a general thing within evidence-based medicine. But then when they do like fueling the use of TXA, while larger, higher quality studies are negative. So that's that's where we are with most of the TXA studies. Besides the CRASH 2 study, it's the only large TXA RCT showing a statistical significant decrease in all-cause mortality with numbers near the of 67. So the CRASH 2 study has also been criticized, amongst other, by Jerome Hoffman in some of his lectures. But in general, in polytrauma, that's where we have the best evidence for TXA right now. And then it's important to give it early. If you have these polytraumas, you have to give them early. Most of these studies show a small risk of harm. So just bear that in mind. That it's not harmless, but it's probably pretty harmless in general. But there's a small increase in thromboembolic events in many of these studies, and in some also a little increased risk of seizures. That's the 2 risks I know of TXA. So I just collected the EM cases kind of in a table, but this is all from EM cases. So check out the EM cases first. So polytrauma, yes, within 3 hours, and the earlier the better. So within 90 minutes is even better. Postpartum hemorrhage, maybe. There's a woman trial and the TRAPS trials. There's a small increase in VTE and low secondary outcome benefit, death due to bleed, but we also have to, like, First NEM made a big blog on the woman trials. We should not be too enthusiastic about tranexamic acid here. In GI bleeds, well, in select cases not included in the study because they didn't, in the whole trials, I don't think they did the biggest, the most, like the patients that were worst off. I don't think they got TXA, so they were excluded. So if you have the patient where you're giving the kitchen sink, you might as well also give TXA. But the whole of the trial was negative. and there's a small increase in VTE. Perioperative, well, maybe there's a Cochrane study saying that it reduced blood loss. Epistaxis, no benefit or harm. So yeah, you might try, but yeah, no massive hematosis in non-massive hematosis. Maybe there might be a signal of mortality benefit. This like in urine bleeds, it was as good as NSAIDs. And then the CRASH 3 trial, well, there's a reduce again in disease-specific deaths, which is problematic. And Justin Morgenstern did a huge blog on this as well in the CRASH 3. But yeah, we often give them in this in head injuries with GCS of 9 to 15, and then ICH, no benefit. But an SAH is in the Danish guidelines still, so follow your local guidelines, but just know that the evidence is not quite good in most of these. The hype that came with the small studies has been mellowed out by bigger studies done in many of these fields with tranexamic acid. Okay, moving on to the next part of this lecture, which is geriatric silver trauma. So there's a great lecture here again from Acute Vecken called TBI in the Elderly, not a no-brainer from Acute Vecken, and by Dr. Rasmus Strandmark, who's Swedish and working in Iceland, and he's studying this as one of his fields of study, traumatic injuries, brain injuries in elderly. And one of his main take-homes is that we're probably missing the boat on what is the main factor here. It's probably frailty more so than DOAC. That is the main reason why, the main factor for doing a CT scan for these patients. But that's not in the guidelines yet. We'll see how this area develops. But check out his lecture; it's really good. If they have a bleed, I'll just show you that there is this what you call the big criteria that you can use to not call your neurosurgeon necessarily, because many of these patients are admitted, but if they're in some of these big categories, you probably don't necessarily need to admit them, but it's a hard sell to not admit these patients in my hospital if they have a bleed. So it begs the question, which bleeds do we want to admit and which bleeds don't we want to admit? And from a neurosurgical standpoint, the ones that, like the subdural hemorrhages that have to be evacuated, are mainly the ones that are where the patient has a GCS that is low. Apparently, according to Rasmus Strandmark, there's now so many subdural hemorrhages and so many elderly patients to operate on that they cannot operate on all of them. So they really have to be very selective on these patients. So it's a question whether we need to admit them as well if they're doing fine most of the time. So check out the big criteria. Don't use them unless you talk with your local area. So, but yeah, worth knowing about. Then when should we scan these patients, and what kind of scans do we do? Well, the scanning to the age to minimize missed injuries. There's a study done by the Eastern Association for Surgery, one of these big trauma groups, and they did a algorithm. They did a study to derive an algorithm to guide the use of CT scans in geriatric blood trauma. It was a prospective study. More than 65 years of age was the inclusion criteria, blunt trauma, and it has sensitivity of 94 and a specific or some negative predictive value of this as well. And I'll show you their algorithm. So here's the algorithm. So if you have a blunt trauma, within 24 hours, obtain a CT scan, head and neck. And if they had an abnormal torso exam or high risk factors, an abnormal torso exam would be tenderness, pain, or pain with inhalation, and so on. And high risk factors would be GCS of below 15, rapid deceleration, platelet or anticoagulation, intoxication, distracting injuries, or emergency procedures having to be done, then you go for a CT scan of the entire, like a silver CT scan. If not, then you only do a CT scan of the head and neck. All right. So because we often find ourselves in these situations where it's hard to know, should we scan the entire patient or not, and the take home is probably that we should scan if they're frail. We should examine the entire patients, and if they have pain, we should probably in the areas that they have pain. If there is more than just the head and neck, we should consider doing more, because often it's a signal of them having several more injuries than we think. Okay, the pelvis. So I talked a little bit about this, and EMKs did a quick hits on them on it about the low risk pelvic fractures that might have bleeds in elderly. There's a small but significant bleeding risk with low energy mechanism pelvic trauma, ground level falls, and it's mainly if they have a shock index that is high, or are they shocky? I had a patient that syncopized and hit their hip and their head, and then they came into the orthopedic part of our emergency department because they thought they had a hip fracture, and then the patient syncopized. The reason why the patient syncopized, we thought, was just the pain to begin with, because the blood pressure went up really quickly. But then it happened again 30 minutes later, and we brought them to the resus bay. And it turns out, and then when we did a trauma scan on them, and it turns out that this patient had both a medical reason why they had a ground level fall or syncope, because they had a third, like a high level AV block. But also the patient had a extravasation in their pelvis, and a fracture of the pelvis, right? So this is a patient group where I've had experience with this. If they have a shock, or you think they are, or they're syncopizing after their trauma, you should consider doing a scan of their pelvis with contrast. Okay. And then you have your trochanter binder. We talked about it already. And do in the trochanter binder, place it over the trochanter, and place it in the stretcher beforehand if you have a high suspicion of an injury. Examine the pelvic region in the ABCDE. Do an inward pressure and touch the region as they're declubbing, but don't. We'll come to that, but don't do don't do up and down motions. Only one person should touch, and so on. Rectal exam, do a rectal exam, and maybe catheterize the bladder to see whether there's any injuries or hematuria, and then ask for if there's blood, and then you consider antibiotics on the rectal exam. Check the 5 P's, which is position of the trochanter, pressure. It should be tight, and they have to be pain managed often these patients. Posture, you have to position the legs internally rotated and with tape. Pain relief, as we talked about, and then pockets. Empty them. There's also a penis, pockets and penis, so that the penis is not in the way. And do a CT angiogram. Don't do a lock roll. Like, the lock roll is going out of favor in many ways. You could do you could just do a small 10 degrees lift, so you could do a blood sweep and then push on the neck. Push on the spine, and do a rectal exam. But you don't necessarily have to do it, especially if it's a high-risk patient, and you just don't go to the CT scan, and then the radiologist has to find out without a high pretest probability of injuries. They just have to correlate afterwards whether there are spinal injuries or not. And don't do these rocking motions. Don't place outward pressure, and don't do vertical pressure on the pelvis. Several videos here will go through these things in general. And you can do this if you don't have this, like tricks of the trade. If you don't have a pelvic binder, you can do like a linen under the patient, and then you do like that, and then you like do a knot, and then you have some kind of something that to hold it, was a piang, something like a surgical scissor to hold it in place. Okay, thorax. So rib fractures in elderly, there's a high mortality per rib fracture in the elderly, or at least it increases per rib fracture. 1/3 develops pneumonia, and the pain might get them to delirium and agitation. Important is to compress the chest and see how they're doing during mobilization and deep breaths. If all that is negative, then I'm okay. And then I don't think they need a scan for the chest. But if they do not, like if they have pain with any of these, significant pain, then I will do the scan. And in young patients, I don't consider doing the scan. I'll just do a normal X-ray sometimes to rule out pneumothorax. But in general, in the elderly, there's a higher risk of, especially in the elderly and the obese, where there's a higher amount of energy from the falls. There I consider doing a CT scan, because rib fractures, we're not too concerned about rib fractures if there's just one rib fracture. We don't do anything about it, but if it's several rib fractures, then yes, we do things about it. And then they might have to be admitted, right? Or it might be a pneumothorax as well. So also think about the lung contusion, and consider doing a abdomen scan as well if they have a tender abdomen. Always examine the abdomen below the ribs, because they usually hurt. The rib and the pushing on the ribs always hurts when they have these. And then aggressive treatment, alvedone and morphine. NSAIDs are usually contraindicated in the elderly, depending on what they're on. But yeah. And then usually admission until you can gauge the morphine dose. And then they need some kind of help at home for the next couple of weeks. Goals of treatment is no pain at rest. So they have to be pain-free statically, but also when you're doing gymnastics or coughing dynamically. So both statically and dynamically, they should be pain-free, or at least acceptable pain. If not, then increase the dose. Okay, so in general, why did the patient fall is always interesting to. It's always something to think about in the elderly. You have your you have the patients who says, "Oh, I fainted." That's a faint. That they didn't fall; they just fainted. Then you have the patients I clearly just fell. That's all right, and then they fell. But the ones that I think I fell, you have to work those up as a syncope in general. Kleck et al. Did this study, or did this hallmark paper or landmark paper on frailty in elderly patients. And so you have a graph here, you have the functional level of the patient and time here in the x-axis. Then you have a line here below which an frail elderly patient will decompensate. Here is independent living, and here is dependent living. So if you have a normal, healthy, young patient, and here you have a elderly patient, so you will notice that the younger patient has a better functional level to begin with. They are living independently, unless they have some kind of disease that pushes them down. But in general, they're living independently up here, and you'll see that the elderly patient is living down here. And the more frail they get, the longer they come down, and sometimes they live under here once they have to be in an elderly home or become demented. Once they get a minor disease like an UTI, this will just get a small bump in the young patient, and they will come up to their own baseline after treatment of the UTI. But in the elderly patients, you will not only get a larger bump, you might not come up to your base level as before, because you might have to be admitted, you might have become delirious, you might have lost muscle mass, and so on and so forth. So this is kind of part of this end of life kind of thing where with each infection goes more and more down in functional level until you incrementally don't function anymore, unless you change this with training and with other things. But so and what kind of symptoms do these patients have when they decompensate? Well, they have falls. That's a geriatric syndrome. So falls you shouldn't just think about, oh, the patient fell, but why did they fall today? So if they're not known to be frail, then the fall might be an indicator that their base level has over the years gone down all the way down here, and they might be more frail than they actually thought. The family will usually say, oh, the patient was doing great a year ago or half a year ago or yesterday. And the reason why they were doing fine yesterday but not now is because of this mainly. They might be more frail than they actually think. And once they get a small disease, then they don't function. They might be confused but delirious, which is like, so they will develop one of these syndromes down here. So it will be a fall. It'll be delirium. It can be the main. Those are the main ones, right? But so it's important to have this conversation with the patient once they fell. Consider if they're above a certain age, 65, or above a certain frailty, maybe. Then you should consider doing a workup for why did they fall. Infection, obstipation, like the minority of the disease, like the more frail they are, the less a disease it has to be for them to decompensate. And if they're non-verbal, then it's really hard to figure out. It's what you call in the literature, in the geriatric emergency literature, non-specific complaints. And that's a high mortality because the patient presents with a fall, but they might have, if they're non-verbal, they might have anything from an ACS to a head bleed to an occult sepsis to a small thing like obstipation, anything, right? So these patients are in a higher risk of having something serious than your average patient when they fall or when they become delirious, because it's much more like neonatal care. They won't be able to present with specific symptoms anymore after a while, especially if they're living down here. But these patients that are living up here but then decompensate, you have to think about, oh, should I work them up for UTI or something else? Polypharmacy as well is a big thing here. There's a world guideline for falls that I will just show you and how to work it up. There's an organization here. One of my friends who was geriatric genius, he showed me this. So check that out and see if it fits your patients. One of these things that is central is the timed up and go test. It exists in different ways, and there's different, like Christian Nichols, who's made one of the geriatric, like he's one of the co-authors of the geriatric emergency medicine books. A Swiss emergency physician, I think. He has done a lot of studies on the sixth vital parameter in elderly, which is, can they walk? Can they walk right now? And if they can't, and they could before, we should consider this a sign of decompensation and a sign of mortality as well. But this is also one. There's more for the stable kind of situation. Like, what is like the timed up and go test for these patients? And if you don't feel they can do this, then you should probably send them to the primary care physician to work this up. Yeah. And here's the study by Mikkel Brabrand, which is a Danish cardiologist and emergency physician, but also Christian Nichols from Switzerland. Should impaired mobility or on presentation be a vital sign? And here's the walking speeds for the timed up and go tests. And here's the, if you're interested, looking at the mortality in the different groups. There's lots of tools in the Stop Falls guideline, World Falls guideline. So check this out if you want to delve into this. Then think about polypharmacy. Polypharmacy is one of the biggest reasons for falls in many elderly. And usually many of the guidelines coming out are not considering geriatrics as a group. Many of the medications are being tested in young patients who are not frail and who are not sick at the time. So once you have polypharmacy, which is I think defined as more than 5 drugs on your medication list, and you're frail and you're elderly, even though it might help you, some of these drugs, and then you have to weigh out the benefits and harms. And many of the drugs don't need to be continued. So one of my pet peeves is that you always, as an emergency physician, need to check out the list of medications. And then you have to pause anything if you've been falling. You should consider pausing some of their blood pressure medications, some of their sedating medications, and so on and so forth. And send them to their primary care physician for a thorough medication walkthrough. Which ones do they need? Many of the guidelines, like for hypertension, would say that, you should have a blood pressure of this and this and this. But that doesn't necessarily apply to your frail elderly patient who is a polypharmic patient and who comes into DD oftentimes for falls. There are other risks involved suddenly than reducing their risk for strokes and so on. So that's a conversation to have with them. But in the emergency department, I think it's important to consider this and signal it to their primary care physician, or just stop the medications by yourself, as long as it's safe to stop them. And there's what you call the seponeringslisten, where like there's different lists of drugs that are high risk for patients in the elderly or frail category. So check that out if you want to. There's Beers criteria, there's the start and stop list. There's different ones internationally as well. But last point I want to give you is, when you have a patient, always consider just don't when you're prescribing something, then always do it with a date. Like, don't do it inevitably, or infinitively. So don't put a patient on Alvedone infinitively. Just put them on Alvedone or paracetamol or whatever, ibuprofen for a 2-week period, or a specific amount of time, so that it will not continue on their list forever. There are some medications that are high risk according to these criteria. This is from the British Geriatric Society guideline, but it's very, very common also in the others. So sedatives, so benzos and C medications like Solpidem, high anticholinergic load like TCA, because this will make them develop delirium, or has a high risk of delirium. SNRIs, opioids, antiepileptics, some of them, but these might be more necessary. Alfuzosin, antihypertensives, and angina medications like nitric oxide. Muscle relaxants, bladder spasmolytics, Furex, which has no mortality benefit but only symptomatic, antihypertensives, and so on, right? So there's risk benefit of these drugs changes once you become frail, once you have polypharmacy. So yeah, this is the book. Now it's become a little bit old now, but this is a really good book on general geriatric presentations, and it's done by these two I know here, really great emergency physicians and or geriatric interested people, like Christian Nichols, who's an emergency physician, and Simon Conroy. I think he's a geriatrician from Britain, but who is nichely interested in the emergency aspect of geriatric care. Okay, facial trauma. You have this patient coming in. What are you not allowed to miss? So don't miss on the minor facial traumas. Septal hematoma, check with fingers or likewise in their nose and see if it's fluctuating. If it's fluctuating, then go to the ENT. Entrapment injuries or trapdoor injuries where they have double vision. It's especially in children where they have a blowout fracture in the floor of their orbital or of their orbit where the eye is. They have to be treated, depending on where you are, by an eye doctor or an ENT doctor. Retroorbital compartment syndrome. So always think about if they have any kind of vision loss or any kind of double vision. In general, trauma patients should be seen by someone. They should have a perfect vision afterwards. It might be a little bit blurry because of swallowing, but when you open their eyes, they should be able to see normally. If they don't, then you have to look for intraocular foreign bodies or retrobulbar compartment syndrome or entrapments and so on. If they have this, you'll do your lateral canthotomy. If they have hyphema, meaning blood in the anterior chamber, then they have to go to an eye doctor for pressure management. If they have a skull base fracture, then you have to consider giving them antibiotics, especially if they have CSF running from their nose or blood running from their ears, meaning that there might be an entry point to the brain. This is low evidence, but there recently was a consensus document being done from the East trauma group about antibiotics and facial trauma. Check that out. There's a cauliflower ear where you just do an auricular block and drain them. You have epistaxis, which we talked about. You have something called a flail mandible. If you have bilateral mandible fractures, there's a risk of the upper airway closing because of swelling. As I understand it, this is called a flail mandible. It should be taken serious. They usually have to sleep upright and then go to a specialist in jaw surgery. I've had a couple of these, and the jaw surgeons usually are unimpressed, so they will just see them in the next day and make them sleep up, sleep sitting up, and then if they get airway problems, then they come in right away. You can do what is called a tongue blade test to kind of, in general, in jaw fractures, whether they should get a CT scan or not. So the tongue blade test is where you put in a spatula and then you twist it. Put in a spatula between their molars on one side, and then you twist it. And if you can break it, then it's a negative test. But if you cannot break it, then it's a positive test, and they might need CT scan. And you do it on both sides. You can check out EMRAP for a video on this. But it's quite easy to do, and it has quite a high sensitivity and specificity. So these are the usual advice from our facial trauma surgeons, that we should link our pictures to them so they can see them. They usually will see a trauma surgeon, a facial specialist, 14 days after their fracture. These patients, they are not allowed to blow the nose, because it might introduce air into their skull. And if they have a TMJ injury, usually they'll have to eat soft food. If you have a patient who, you'll usually advise the patient to, if they have a runny nose at any point, then they have to go to an ED to see whether that's CSF and then whether they need to be treated with antibiotics. If they have any, as we talked about, if they have any vision problems, then you have to go to an eye doctor. How fast depends on what you're suspecting. If you suspect IOFP, like intraocular foreign body, or retrobulbar bleed, then you have to do a lateral cathotomy. If it's an IOFB, then you send it to an eye doctor right away. So, but if it's hyphema, you just call them and then you see, like, usually they'll see them the day after. Then you have teeth and nasal fractures. If you have a nasal fracture, then you, without septal hematoma, they usually have to come back 6 or 7 days after, or 5 or 7 days after, when the swelling has gone down, and then with a picture of themselves, a selfie, and then the nose can be put back. Dental trauma. Okay, so dental trauma. There was a great lecture on Akutvekken about this, and I'll just refer you mainly to this, and I'll just walk through some of the main points. There's different nomenclature of the teeth. There's 32 in adults and 20 in children. It's good to have some kind of, to know somewhat where the teeth are and how to tell them apart, like how to when we're communicating with radiology or anyone else, and it's always good to just think about this and then pull this up to say which tooth is injured. The anatomy of the tooth is like this. You have the crown, the neck, and the root. In general, the root is not supposed to be exposed at all, and we'll come back to that. It's not supposed to be brushed either. It should be handled really gently and not be touched. The crown has this really thick material called the enamel, and sometimes with a teeth injury, you have to know about the pulp, because if the pulp is exposed, then it will die within very short. And sometimes we can do something about that. There's a Andreasen classification, and you can check out the Danish homepage, which I referenced earlier, where it's sadly now a pay-per-view kind of site, but here you can see the nomenclature as well. Some of the emergencies are, if you have teeth in wounds, it's really important to remove these. It can be kind of hard to find sometimes, and sometimes the wounds are closed. So do a CT scan to check out whether there are foreign bodies in the wound, because this will develop infection if there is teeth in the wound. Complicated dental fractures, like pulp exposure. You have subluxations and luxations, infections and bleeds. Depending on where you live, you might have to treat this. In general, complicated dental fracture where you have a red dot in the enamel, then put on what you call calcium hydroxide. Not on the enamel, but on the pulp, otherwise it will die within a few hours. If you have a subluxation, a loose tooth, mobile tooth, then you have to splint it. I'll show you how you could do it. If you have a luxation or avulsion, you will have to do the same, but you have to put it in first, and then you have to tranquilize the area. I've never done this, and I will refer you to the lecture from Akutvekken, which is amazing at showing this. So here's, if you have a pulp exposure, you'll see the red and a little red, and you will have to put on this Dicel right on that area, not in the enamel, but just right on that area, which will kind of keep it safe until the dentist can see it. Otherwise, it will get ischemic quite fast. Subluxations and luxations. So if you want to do single tooth anesthesia or periostal block, you can do it by pull out the lip, insert a needle at the highest point of the mucosa, advance to the bone, and pull away 1 millimeter. Do not inject into the periosteum. Yeah, inject 1 milliliter and then inject a small volume on the inside. There's a YouTube video of this as well. And you'll block that area up to that teeth, up to that tooth. You can also do like more regional blocks, and one of the easier one is the inferior alveolar nerve block, where you come at an angle from and try to tranquilize that area here. You can also see a video of this here. So how do we handle a tooth? So local anesthetics, and if a tooth has been avulsed, you should put it in milk or a normal saline. Don't touch the root, right? Don't touch the root, and you have to be put in right away in milk or in normal saline. So as fast as possible, otherwise it'll dry out. Within an hour, it'll dry out. So you don't have that much time. Remove debris from the socket. You might have to gently rinse the root if it's really contaminated. Then reinsert the tooth. Make sure it's aligned vertically and horizontally and sagittally and on all planes. And check whether the patient can occlude their teeth. Make patient bite down on the spatula to stabilize the teeth. And then use steri-strips. This is a method done in a study. These are pictures from the study, where you 2 teeth on both sides, do broad steri-strips and 2 teeth on both sides, and then put a little bit of glue, and then put several layers, 4 to 6 layers of steri-strips on. Yeah. So I've never done this again, but if you're in a situation where you have to do this, and check out the lecture from Hjalti from Iceland. He did a great one talking about this. Then you might sometimes see infections and bleedings. And infection and bleedings in teeth are, so check out Hjalti's lecture on infections. You might have to release these infections before they go to a dentist. Oftentimes we do a CT scan to see whether there's a big abscess system or not. And when it comes to bleeds, well, that's usually a bit complicated. Oftentimes, if they come out of hours from where they cannot see a dentist, then usually it's a huge problem or it's a big problem. And the main thing to do is bite down on a TXA, a cloth with TXA on it for a long time. If that doesn't help, then you have to resuture them, and it's often hard to resuture these patients after some kind of surgery in the mouth. It's not something that we as doctors usually learn. So yeah, many of these patients often overnight at our hospital for observation until they can go the next day to a dentist. It's usually elderly patients with anticoagulation. Okay, minor head trauma. So my tips on minor head trauma are not magical or anything like that, but this is the Scandinavian protocol for minor head trauma. We usually do. I very rarely admit patients for commotion or for head concussions. I think it's if they can go home to a home where they have someone who can watch over them, I would not do that in general. If they have a bleed on the CT, it depends on whether it's an epidural or a subdural or an acute or a chronic. So I'll ask neurosurgery, but you could use the big criteria, it seems, which we talked about. if they're not, I will admit sometimes, if I will admit them if they're not not normal, if they have amnesia or confusion, if they don't have a home to come home to, no one who can check them out, especially if they come during the late evening or night, or if they live really far away. S100B is often part of this algorithm. It's not part of the algorithm internationally, so it's kind of, we don't know why it's so popular here in Scandinavia, and not all places use it, and it's not, and it might, like, this group that came up with this thing might be heavily influenced by Roche, who made it. So I don't know, but it's not, a lot of places where I work don't use it. Frailty, probably the best marker of head bleeds. We talked about that. Liberal use of CT neck if you have elderly patients over 65. Consider scans, especially in the elderly population, if wounds need suture. Yeah. Neurosurgeons operate on GCS and focal neurology, so if this subdural hematoma is not that big, or if it's big but they have normal GCS and they don't have neurological focal neurology, then you should usually just admit them and do a new scan the day after. Remember to inform about SDH risk. Yeah, so even if you did do a normal CT scan with the patients, they have to be aware that SDH can develop, especially in the frail and the elderly. And so if they become demented or confused in the next couple of weeks to months, then they should consider doing a new CT scan. And yeah, just an add-on here in Stockholm, that there's a discussion going on whether all patients with anticoagulation should do a CT scan or not. As we talked about, with frailty being the better marker, and which kind of anticoagulation should do a CT scan, and so on. And should they be admitted or not? So they probably should do a CT scan as it stands right now, but should they should they be admitted? Yeah, that's always a discussion point. Because we will usually just do a CT scan on them. Then concussion or hjärnskakning. There's come out a new big criteria for new criteria for these, ACRM 2023, and I will not go through all of these. It's the take home, I guess, is it's hard to say whether you have a concussion right now, but if the more symptoms you have later on, the more likely it is that it's a concussion. Some of the criteria are like this. So the mechanism of injury is traumatic brain injury results from transfer of mechanical force, head being struck with objects, head striking a hard object, and brain undergoing acceleration. So you can get a concussion by just having a fall where you didn't hit your head. Even though that when you hit your head, normally that's how you get the concussion, but you can get it by just the brain being shaken within your head without the head ever touching the ground, and also from blasts and so on. There's other criteria here. You have to have like loss of consciousness or immediately following the injury. That's not, you don't have to, but alteration of mental status immediately following the injury, complete or partial amnesia, other neurological symptoms, and then acute symptoms. Two or more new of these, right? Clinical exam, laboratory findings, and so on. So if you want to go into how to diagnose this, is more like it's outside of the ED. I'll usually just tell them that they might develop a concussion, and then I'll usually say that the first 48 hours are important, that they should decrease their activity level from 100% to maybe 30%. They should not be 0%. They should walk around, take walks, talk with people, but both emotionally and work and training wise, they should not put too much pressure on themselves. They might be brain tired or have a period of maybe 24 or 40 hours where it's okay to tell your like surroundings that they cannot demand too much of you. After these 48 hours, they should incrementally go back, and how fast these increments are depends on what kind of symptoms they have, how many symptoms they have of concussion. If they don't have any, they can usually just go back. I usually tell them that this might last for a few days to maybe maximally 2 weeks for most people, but if it lasts more than that, then you should go to see their private care physician to consider sick leave from their job, which is normal oftentimes with these head injuries, and they should consider doing some kind of neuro rehabilitation, because these injuries are now classified as minor traumatic brain injuries. So it's, but there's in an article by experts in Sweden, they say that if the traumatic brain injury was not caused by sport-related activity, there might be a paradoxical effect of doing this kind of incremental thing, and so the jury is out on which patients to use it exactly on, but especially sports injuries, it seems like this is a good idea to rest 40 hours and then incremental go back. Yeah. Exactly. Canadian C-spine. So for the C-spine, there's different rules, right? There's the Canadian C-spine rule and there's the nexus criteria. The nexus is a little bit more up to the clinician's choice, depending on what they think is intoxication and what they think is a distraction injury. The Canadian C-spine rule cannot be used with a patient over 65 years of age. Not too much to say about these other than they are pretty much interchangeable. Justin Morgenstern has done his vodcast on mastering diagnostics. He talks about if you use both of them, you can't have one of them positive and the other one negative, and don't necessarily. Yeah, you can check that out by yourself. I don't want to do any conclusions on that, but in general, use whichever one is used at your hospital. And if they're above 65, these patients were excluded in the studies, so you can not really use that on those. Yeah. Pediatric trauma. The basics, you can use PediStat, EPET, or COPI. Blood boluses are 10 to 12 milliliters per kilo. TXA has low evidence. Glucose in all infants. Head trauma, you can use PCARN rule. Spine, you can use the jump test or the PCARN rule, which is controversial. Check out first 10 EM's block on that. Thorax, unless risk of aortic injury, CT chest is usually not recommended. There's no PCARN rule on the chest injuries. You can usually use a POCUS to check out if there's any other things here. But in general, thorax is not important, or not that it's not important, but it's not you don't need to scan. You can scan selectively there. Abdomen, EFAS is much less sensitive, but it's still specific. Sensitivity may increase by doing liver tests and consecutive EFAS, but otherwise you can use the PCARN CT rule for abdomen as well. Extremity fractures in children, you can check out the SWEEP-HEME compendium for sedation and how to reduce how to reduce it, and you can check out my other video on sedation in children, but also the ALB compendium or similar like cookbook on how to manage different fractures in children. I did an entire video on orthopedic injuries as well, so you can check that out. Non-accidental injuries, always think about those. Okay, so sutures in general, there are two great resources here. There is the First 10EM/Journal Jam EM Cases podcasts on everything about sutures. There's a 3-part episode going through all the known evidence, I think, on sutures and everything around sutures. So check that out if you want. And there's also this homepage called Closing the Gap, which is made by a now sadly deceased emergency physician. Check that out to see all videos on sutures and like what kind of sutures you can do and so on. I usually also use EM Wrap because they always have quite good material on certain sutures as well. The doc analysis, like in general, this is just some. You can check out the EM Cases Journal Jam for the summarization of these things as well. But golden period for wound closure, no, there's no strong evidence for that. If you go much beyond the 6 to 12 hours, then maybe you should have antibiotics on board as well. But it's not high evidence. Always clean the wound before. How to close the wound edges for good healing? Well, close enough is probably the answer. There's no aesthetic evidence that different methods are better than others, and there's quite a high margin of how close it has to be together to have a good aesthetic result. Oftentimes when you suture, the patient is very concerned about the scarring, and I always tell them that you will get scarring. It's important to tell them that up front, but the scarring minimizes when we close the wound. Irrigation, tap water is all right. You don't have to use sterile water. Clean on wounds reasonably and remove debris, especially teeth, for instance, or foreign bodies. Sterile gloves versus clean gloves, no evidence in using sterile gloves. Closure of wounds. Well, glue is, is good for wounds that are not stretching. You can use the hat technique, the hair apposition technique in kids and people who don't want to be sutured in the hair region. Steri strips for small lacerations, absorbable sutures, no need for removal, but it takes a while before they are removed. They should not be in the water with, like, there's low certainty evidence that they should not probably be too much in the water when they have these. There's a higher risk of infection, but not much. Non-absorbable should be removed by their primary care physician. Aftercare, well, get wounds wet, very low certainty of evidence, but it's probably safe to get wounds wet early after repair, and keeping them clean with soap and water makes physiological sense. Avoid soaking in pools. Dressing, the current evidence is very weak, and there does not seem to be any evidence that dressing improves healing after acute laceration. It makes sense to use the dressing for comfort and to absorb blood and exit it in the first 12 to 24 hours of repair. Obviously, the patients can continue to use the dressing if they want to. Sun exposure, no evidence at all. Ointment, lack of good evidence. So he says this: after spending a large amount of time reading literature about laceration repair, my theory is that our interventions have very little impact on outcomes. The skin is going to heal itself. We want to ensure that the skin is clean and the edges of the wound are together, but how we accomplish that goal doesn't really matter. The data seems to support that theory, so my final answer to the question, how far should my sutures be placed, only as close as they need to be to approximate the skin. Yeah, so in general, not a lot of evidence for a thing that we do a lot. These are the kind of sutures we have. There's Vicryl Rapid, which is like the Vicryl are the self-resorbing So wound supports for 10 days and the complete reabsorption in 42 days. Monocrural wound support in 20 days, complete resorption in 90 to 120 days, and bicold sutures 30 days. And yeah, and you have your Dermaflex dissolvable sutures. What information should we give? Well, your doctor will tell you if the child has dissolvable sutures. Dissolvable stitches disappear by themselves and do not need to be removed. This may take up to 2 weeks or longer in some cases, and it's important to not get the wound wet for at least 5 days. Glue, keep the wound dry. Your child may have a shower and brief bath after 24 hours, but do not soak the wound. Patients pat the wound dry with a towel for a shower or bath. Do not let your child go swimming or soak in water for 7 days. Do not let your child rub or scratch it. Do not use cream or ointments over the glue and so on. Yeah, and the scab will fall off. Okay, so that was all I had for you today. You can check out Figure 8 Sutures on your own on MRAP, which I think is the only really good suture to know besides normal simple sutures. Of course, mattress, horizontal and vertical mattress are also good, and yeah, it's good to have an arsenal of sutures that you can do, but I think normal sutures and the Figure 8 are in the emergency department, so the best one to know. Okay, I didn't go into too much about different lacerations, areas where we shouldn't suture. We could have talked about, well, medial eye aspect around the tear canal should not be sutured. We should not, or not sutured by us. Complex wounds, lip wounds, and so on. There's lots of things that I didn't go into here. These are just some general rules of thumb. So that was all I wanted to talk about with you today, and thank you so much for listening.